You see, the CTO PCI from the last 15 years has taken many shapes, many algorithms, depending upon the different operators, innovative techniques, putting together, becoming one algorithm. This is what is happening. So, for any algorithm, there are certain common things which is a must. So, in 2012, in my practice, last 15 years, almost 16 years, I am doing CTO PCI, and then more than 1500 CTO PCI in 15 years. I'm watching it, the progress of the CTO PCI. 2012, I thought the retrograde procedure will become more popular that time. Then the Gaia entered into the market and made big change into robust anti-grade procedures. So many things happening like that. Most important thing is the hybrid C2 algorithm, which is commonly followed. Still, the most important thing is the dual injection. In all these things, the dual injection is the must. So what we see in the dual injection is the proximal cap, the distal targets, the length of the lesion, and the collaterals. These are very, very important. Then you will decide. So we have to spend time studying this dual injection in one caudal and cranial view. For learners, this is very, very important. The success story depends on learning and analyzing number of times this dual injection. So in this particular algorithm, there is a, if you find the ambiguous cap and poor distal target and appropriate interventional collaterals, if you don't find them, antegrade procedure is the preferable choice. Like, then you see the length of the lesion. Yes, if it is less than 20, the antegrade wiring is the simplest technique any operator will prefer to pass through a single wire array and a wire escalation technique, the most preferred technique for any operator. And then if you don't find, then the things start. So there are many things. The European operators, US, they prefer the areas most. The people who in Japan and trained by the Japanese prefer to go to a parallel wires than the retrograde procedures. So now putting together, many algorithms have come into the picture. So this is one. In this algorithm, particularly the escalation of wires and antegrade dissection, and the retrograde true lumen cross and retrograde dissection entry. And these are the things what followed in this. But hybrid procedure, don't waste the time. The principle is don't waste time on one technique. Try to switch over fast. So the idea is to minimize the contrast, minimize the procedure time, minimize the radiation. The success rate increases when you wire cross is less than 30 minutes. That's the principle. So the ABC2 algorithm is a combined Japanese, Dr. Tsuchikeni has made a beginning for this with, along with the Chinese operators mainly that time. In this only thing is the CT angio also taken into consideration. And in this, the importance given to the ISR CTO, where the cross-bus is a very nice device. And Dr. This cross-bus makes good use of cross-bus as a primary crossing in this particular algorithm. As before, the proximal cap ambiguity, distal vessel size, and very important, if you find any branch near the bifurcation, good sizes branches, then the story totally changes. So we don't prefer the ADR when you find it's very close to distal cap to a large side branch. Then the parallel wiring, yes, parallel wiring is a very favorable technique. Whenever we discuss with Dr. A.B. Mehta and all previously, we used to load a lot of parallel wires. Then people thought it will go away. No, parallel wires still. Recently, I have done 3-4 cases as a proctor. Finally, I have come back to parallel wire and finished the case, because parallel wire, if you do it in a limited way, without wasting much time, not long procedure, don't produce much hematoma, intramural hematoma, without true lumen closure, it's a very good procedure, there is no doubt. But later, this IVAS guided entry, now is now the modality which many people prefer, particularly in antegrade procedures. The IVAS guided entry can be made to put a proximal cap puncture by putting a side branch. You need a good side branch to accept and the catheter also selection is very important. The tip to transducer distance is 2.5 millimeters ideal. Volcano Gila is a good catheter, but other catheters, many things coming into the low profile catheters have come, many techniques have come, even you can pass the catheter, jubal lumen catheter drivers. So these techniques have come, and you can also do the virus IVAS guided entry. Once in the subintima, you can enter a wire to lumen entry by the IVAS guided. So in this particular thing, the IVAS guided entry, the ISR made a difference. And intervention collaterals are there, always retrograde procedure there. So you can become a complete CTO operator when you know the anti-grade techniques, robust anti-grade techniques, then you go for a ADR, if it files a retrograde. So a comprehensive approach, putting together everything, then you become a full CTO operator. But always consider a knuckle wire. In knuckle wire, people are scared to put a knuckle, but you should be careful choosing the size of the knuckle. You can choose the size of the knuckle by the IVAS, or you can see the size of the vessel or the angiographic, and you should know how to make the knuckle, what wire you should use. The good wires like a Fielder XT, the Cyan Black, the Pilot, the recent Gladius, there are good wires for the knuckle. So whenever you find a very long ambiguous cap and a tortuous CTO, heavy calcification, yes, if there is no option, you can have a good knuckle anti-gradely, safely you can. And very important thing is if somebody failing many times, this is also a very good technique, previous failed attempt and long lesions more than 20. So these are the techniques which added in this particular. The CTO club chain has a mix of this epi-CTO because it's a combined effort by the Japanese and the Chinese. And the same thing, they also used the angiogram. The proximal cap plays key role in this. And in this also, the IVAS guided approach. Again, if you find difficulty in the anti-grade, if you got good collaterals and digital targets are good, I always feel, I look at digital target, very, very important. Either you do an anti-grade procedure or retrograde procedure, if you have a poor distal vessels, the success rate is not there. And another very important thing, I take up in my proctorship, if there is no retrograde vessels filling only by bridging collaterals, that's the most risky thing. If the patient has a viable myocardium, will land a problem. So see that there's some retrograde collateral always safe, and then you have to be more careful in crossing these lesions. So as before, the lesion length place here, the distal diffuse vessels and side branch near the landing zone. These are the important things. Again, the parallel wire has come into this algorithm also, very important. In the reverse retrograde technique, a simple true wire, true lumen, 30% still happens. That's a good thing in reverse retrograde procedure. 30% the cases, true lumen to true lumen you can enter. And retrograde escalation with a simple wire escalation and knuckle wire can be used. The next is the Hero CTO club. Here the Hero CTO club, they do lot of this here. They concentrated mainly on procedure time, limitation is there, 3 hours, contrast load. We are not that, if you are nearer to the success, we usually prolong it. But Europeans, I have seen Werner many times, mainly keeping concentration in the air kinema, which is very important long run for the operator and the patient. And in this also jewel injections, but the crossbars played an important role in this particular algorithm. And the other things are same, switching over to the retrograde whenever you find a difficult antigrade, like a base technique used. You can create a dissection with a large balloon at the proximal cap if there is no side branch, important, and use the ADR at the IVAS guided techniques. So most important thing, if you can cross these regions in 30 minutes time, wire cross, success rate is more. So fortunately, I am also I contributed a little bit to this particular algorithm by Dr. Bilakis and my colleagues, CTO colleagues, many from India. And this, again, dual injection is very important. The proximal cap ambiguity, distal size, anti-grade wiring, parallel wiring also played in this also. So parallel wire come into picture again, that's very important. The mix of the European, like they move the cap, the intravascular ultrasound, these are the, but again retrograde approach comes whenever there is a difficulties. Again, in this, important thing is estimate, they consider the when to stop, very important. We have done couple of procedures. The investment procedure means that if you have a small flaps and distal flow is there, but you cannot stent, stage it after a couple of weeks. I stage it around 8 weeks time. This is time when heals, and you can put easily a simple filter XT like wire for the lumen cross and stent it. It happens and success rate is good. So this is the simple approach. Like this is a beginner's approach, like you do a dual injection, read the proximal cap, length of the lesion, calcium, collaterals, so this one is the simple approach, like a contralateral injection and simple wire cross. A beginner should always attempt in all algorithms with this technique, with the escalation of the wire. So this is a parallel wire technique. You find it's false lumen. Second wire should be always a more stiff wire. And in multiple use, you see this, and a parallel wire technique is very useful still.
I think, Surya, you can run through the case. I just ended the short of time.
So the other is, I use in some cases, if it is in the knuckle, in the false lumen, then I can try a parallel wire like this also. In the side branch wiring, I have done many cases like this, put a side branch distal, always a good sign. People think side branch a bad sign, but a distal at the site of the lesion, a side branch, you can do IVAS guided puncture. You know, people, if you got a side branch good sized, you can put that and pull back and find the proximal cap and puncture it. So this is the classical, another, take a retrograde also is a kissing wire, then you can cross from the anti-grade IVAS guided wiring. This is also very useful. And I've done some cases, the limited last technique, like I use in this case a Corsair guided re-entry, a limited subintimal tracking, still used when, but I don't advise these things when the simple things work out, don't go for knuckle, as I explained, long knuckles, star technique not used nowadays, but at the last resort, sometimes we have to do this. I have done some cases, results are not that bad as expected, subacute thrombosis or restenosis, not as people used to say before. Then the crossbars as discussed, this is now becoming more familiar with less and more, if the distal calcification not there, good sized vessel, no branch, side branch, this is very used. The base technique, as I explained, you mainly used by the Europeans. This is a balloon dilatation, and the retrograde approach, you know, the reasons I don't go into details. But if you find a good septal collaterals, always prefer the epicardial collaterals, last resort, and the good tools you have to change the septal collaterals, change the collaterals if you don't find. Simple wire cross, as I said, is very useful. If you don't find reverse cut, is very simple technique. Use a low profile balloons, simple reverse cut, you can exchange externalization. Sometimes you have to use a guide liner if you don't want to injure the ostium or the left main. These are different types of reverse cut. I am not going to touch this. And there are 4 patterns of the IVAS you should know. If the retrograde wire is the intima is the very difficult thing in these 4 patterns of the IVAS. And a knuckle bias, sometimes it is also there in the algorithm.
I think you should summarize. Yeah.
This is
okay.
last. This is over. So by this you can do this. So this is also ipsilateral thing. You can use the IVAS always. And so when to stop is important. Consider stopping if it's more than 3 hours. Most of people agree. If the more than 3 into EGFR contrast, and air can move more than 5 gray, what we are following, unless procedure well advanced. But of course, none of the rhythms mentioned. I feel patient and operator fatigue is very important. Thank you.